we have seen complicated cases, but we also have complex malformations where the decision making is not as easy as the other standard cases. So I actually brought some cases to our distinguished panel members to see our decision making. So they haven't seen the cases, and actually I will present them these cases and see what will be their decision. And we have Dr. Amit Kishore, Sunil Bhatt is not here, Shankar Medikeri, radiological, but together with our audiologist. We also have our speech and language therapist also in the team. So we always discuss, repeat MRI, repeat audiologic evaluation, then we decide in majority of the cases. So I will show some cases to you. Definitely, it will not be a case like this. You see, we have beautiful nerve on each side. We're not going to discuss these cases. But if you look at this patient on the right has a nice nerve. On the left side, we have a hypoplastic nerve. But if you look at the cross-section, this is right, this is left, we see the nerve, and I think there is no doubt here that we will do cochlear implantation. Do we have any doubt? No. So we are not going to discuss cases like this where we can see the nerve even though it is hypoplastic. So ABI has definite and possible indications. Definite indications are, I will not show images, but cochlear labyrinthine aplasia, cochlear aplasia, aperture aplasia, and nerve aplasia. There is no possibility to do cochlear implantation in these, so these are definite indications. We also have possible indications. So these are the difficult cases where we have hypoplastic cochleas with aperture hypoplasia and common cavity and IP1, because we are not 100% sure how the cochlear nerve is distributed, or unbranched cochlear vestibular nerve. So this cochlear vestibular nerve is there, unbranched, so we don't know how it is distributed in the common cavity, and also very thin hypoplastic nerve. So this meeting is actually about this very, very thin hypoplastic nerve. So this is the first case. This is the right side. And we see, what do we see? I mean,
seems to be a cochlear aperture stenosis.
Exactly, cochlear aperture stenosis. This is the axial view, and this is the coronal view. You see that the aperture is not almost reaching the cochlea, huh? And this is the other side.
Looks the same, I'm not sure.
Yeah, it looks the same. Completely right. Dr. Medikeri? Yeah. We have maybe a small cochlea, smaller than normal. We can call this hypoplasia type 3, but more important than that is the aperture is almost aplastic or very hypoplastic. So when you look at the tomography, you don't think that it will benefit from cochlear implantation. And this is the MRI of this child. This is the right side. Dr. Medikeri, what do you see?
I am seeing on the MRI there is a cochlear facet in the basal turn.
Yeah.
Does that mean that the nerve entering there?
Yeah, there is a very hypoplastic nerve. He's right. Yeah. There is a very hypoplastic nerve going there. And let's look at the other side. This is the other side. This is the other side. I mean,
this side I think it is blocked. No,
yeah. It must be a stenosis. You think that there might be some slither of fiber going towards the cochlea, but it's not very convincing.
It's not very convincing. They're right. So
look at the audiology.
Based on tomography and MRI, what do you suggest?
I would suggest to work with the audiologist.
Exactly. This is very important. I mean, don't look at the scans only. So work with the audiologist. They're right. This is our audiologic test. and our audiologist obtained thresholds like this. Do you want to make any comments?
These are unaided.
These are unaided,
Unaided.
yes. Yeah. With the microphone, please.
They're not at the maximum, but this is VRA.
Yeah.
So this is with a speaker, right? Or I've used very large
You know, I'm
headphones.
surgeon. I cannot tell you the details of the audio ground. But insert earphones, maybe yes, but these are the thresholds. So my point is, with that MRI and tomography, it was impossible for me to expect a result like this. So what will be our decision?
The first thing is,
They're
of
not
course,
at
This
the
was-
maximum. They're not at the maximum levels. So I would think it is a hearing. It is not at.
Yeah, okay,
the
you're right.
other thing is, of course, they will tell me that these are definite audiological response and not vibrotactile because it's low frequency.
It
Yes.
doesn't look like vibrotactile because
Yes.
mid and high frequencies are also there and they are like.
I also think the same thing. So what are we going to advise to this family?
I think we should take them for hearing aid and look at the aided detection thresholds
Yeah.
and also see if the child is getting any auditory input with hearing aid, because if they have this audiometric threshold unaided, I'm sure there is a potential to give a amplification device and look at it.
Yeah.
And then the decision can be more reliable instead of just basing on this audiometric threshold.
We did that, and
Just one more point.
yeah.
See, because this is a 2-year-old child, and you're putting in, even if you're using insert, it is calibrated for adult ears. So here it may show 70, but in the ear it's actually, it will be little more, 10 dB more at least.
yeah.
So still it is not at the totally bottom. So
Not at
with
110,
hearing
115.
aid and therapy workup, we should be able to.
So, if with the answer to your question is if with the fitting of hearing aid and repeating the VRA or conditioned response, if they can show a slight improvement with the aided, then I would be more encouraged to advise the family to consider a cochlear implant.
Yeah, this is actually what we have done. My point here is this child was operated in 2011, and with the cochlear implant at that time, at that moment, we were doing only unilateral cochlear implantation, and he developed completely normal language. So at that time, only unilateral implantation was possible. Now we wrote this child to the special commission to get a second ear implantation also. If they allow us, we will do the second ear as well. But my point is, don't look at the tomography and MRI only, because it is so hopeless. You see that tomography and MRI, but the child is normal language development.
I just want to use this opportunity to suggest there was a case instance wherein the MRI had reported totally opposite. So the left was better than the right, and they had reported totally opposite. And in the audiological finding, we were like so perplexed because every time the child was responding better in the other side, and then it was repeated, and it was discovered that the other way was correct. So as going with you, it should be both ways. Both has to go hand in gloves, collaborate.
Exactly. So, this is another 2-year female patient with this tomography. The tomography doesn't have any very clear pathology. Maybe the aperture is slightly narrow.
Maybe this is stenotic aperture.
Yeah, maybe slightly narrow here, but you know, we don't expect a lot of pathology here. But let's look at the MRI. So this is the MRI. I will show you one by one, and you tell me what you see, Dr. Amit. The cochlea is normal. So here
Yeah,
is...
there seems to be a nerve going more on both sides, in fact, I think.
Yeah, both sides there is a very, very hypoplastic,
Yeah.
very, very thin nerve. Huh? Okay, so this is again,
Yes, you're getting good aided responses.
yeah. So these are the aided responses here. But I think it is insufficient to wait with the hearing aid in this. Such a MRI is important because it guides us about how long we should wait. I mean, we cannot rely on hearing aid in such a thin nerve. Don't you think?
I agree. The aided response is not to tell me whether the child is going to get good benefit with the hearing aid. We don't expect that.
Yeah.
But it's enough to tell me that the child is getting some benefit, and therefore there is connectivity, and therefore with the cochlear implant I would expect it much more.
Audiologists are sharing the same.
Yeah, of course, finding a detection aided threshold is excellent. Just to begin with, I would request surgeons not to end there because we have to also look at other abilities of development of auditory capabilities, as Dr. Madhuri Gore pointed out in her talk, that it is important to see that other abilities are also getting developed, and then we should, because we know already the nerve is compromised here, and if other aspects are compromised, the outcome will be really limited. So especially in these particular cases, I would again like to highlight that just the detection threshold should not be the ending point for decision making.
We usually follow these patients 3 months.
Vijay, we do need a therapy, I think, with this because the child had to be conditioned to do, because it's a 2-year-old child, for finding the aided thresholds without just for the first time only. If you put the hearing aid and doing it, it may not be possible to do it, or you may not get the correct picture. So a child has to be fitted with the hearing aid. We know that it is not going to definitely benefit, but do some amount of training and train the child, and then do the aided threshold, and then.
Yeah, exactly. These are definitely, we do the test, we repeat the test, we follow these patients. We don't decide usually in one setting. It's impossible. So, but we need to take time to make the correct decision.
And in the therapy, you will see how the child is responding,
Yeah.
the vocalizing, even if they are not exactly saying, from their voice and the variety they have, sounds they make, which helps to make a decision.
So for this patient, we did cochlear implantation on the left side, as you see here, and she's been followed with the right side hearing aid, and she made very good progress, but depending on her progress, we can do cochlear implant on the other side or follow with the hearing aid. Our point should always be bilateral stimulation, whether it is with bilateral cochlear implantation or bilateral hearing aid or CI on one side and hearing aid on the other side. So this should be our goal, and this patient we managed with hearing aid and CI on either side. This is a little bit more complicated case. Dr. Amit and Dr. Medicari. So you don't expect me to ask these images to our audiologist, huh?
Well, we can test them and see if they were listening to your talk.
Ah, okay. So hand the microphone to your audiologist.
I'll spare them.
These are the only two cuts that we see the cochlea. Huh?
Okay. So extremely, it's of course hypoplastic. You just see a basal turn.
Extremely hypoplastic cochlea.
You don't see any vestibular cavities or semicircular canals, at least on these cuts.
Yeah. So these are only basal turn. We don't have the middle and apical turn. So it is extremely hypoplastic. This is the side, right side, and this is the left side. Exactly the same.
Very similar. Yes.
Picture, huh? So when you see a patient like this, tomography, what do you expect?
And sorry, is there an internal canal or is that all you have?
We have an internal auditory canal, yes. But not on that section. But I will show you the.
Yes.
We have
Posterior
vestibular
canal.
system, posterior semicircular canal here. You see this is the cochlea on the left side, very hypoplastic, consisting only of the basal turn. Yeah. We have the vestibular system, but this is the internal auditory canal.
Yes.
Very good internal auditory canal. What is this nerve?
It's a vestibular nerve.
Vestibular nerve.
Vestibular.
Yes. And what is this nerve?
Facial.
Facial. So, because the cochlea already finished, and cochlea is here.
Yeah.
Okay. So, this nerve cannot be the cochlear nerve. So, if you actually see the whole tomography, that's the facial nerve. You're completely right. That's the vestibular nerve, and we don't see any connection here with the cochlear nerve. Okay. With the cochlea. So the cochlea is there, but there is no connection. But let's look at the right side. So this is the right cochlea. Left, sorry, left. Okay, so please carefully follow this. You see there is something here. This is, what is this nerve? Vestibular nerve. Okay. What is this nerve?
Facial.
Facial. So, is there a difference between right and left side?
I was wondering whether there's a little branch going off from the vestibular.
Yeah. Very tiny branch that makes the difference.
What does your audiologist tell you?
Yeah. So now it comes to the turn of the audiologist. So this was reported as bilateral cochlear nerve aplasia, but please don't look at the reports only. Look at the scans by yourself, one by one, because every patient is different. So there is only basal turn is present, and there is a tiny tweak on the left side. So this is the our audiologist evaluation, and I will show this patient's audiogram, actual audiologic evaluation to you. We hear the sound. So there is a response on the left side. So this is the child. When it comes to high frequencies, there is a response. Why? We have the basal turn. Look. The child is distracted. So we have the basal turn and high frequencies, there is a response, but we don't know which ear is causing. So the child definitely has a response. So we always test these patients with insert earphones. So this is the left side. And again, they test the patients with two audiologists. So she is distracted once again. But look when they give the sound to the left ear.
What?
Look. Look. Now the sound is produced to the left ear, and then she looks at the audiologist. So this is very characteristic. Look, she looks at the audiologist, but in order to see these responses, they need an hour, maybe repeated, because they're easily tired. You know this much better than me. They need a lot of work. So it's not just like our ear examination. Our ear examination is very simple. We remove the wax, look at the membrane, we send it to the audiologist. It's not like that, huh? So they take a lot of time. So our plan on this patient was this. I don't know if you agree with me or not. Do you agree with me? I mean, maybe you have more experience with ABI, with Shankar.
I don't have any experience with ABI.
But
I think that if the audiologist is able to, the response was, of course, levels are very poor, but there is some high frequency and get a response, then we could consider with a cochlear implant on that side. Of course, prognosis very, very guarded. It's a hypoplastic cochlear basal turn, so a much shorter array because we don't have to, we want to get too many electrodes, and so those are the things that have to be considered.
So the function of the imaging here is this.
Can you do a TT ABR in this case? Check the left side.
Yeah. Thank you. We have also developed an intracochlear test electrode.
Okay.
And use this. I will come to that in just a moment.
Okay.
And I think they are less valuable to us in cases like this. But more important is the actual observation during the audiologic evaluation. So the value of the tomography and MRI, there is a tiny basal turn. And when we look at that tiny basal turn, it's impossible to expect a very good outcome with a cochlear implant. So I operated cases like this. It is even not possible to fully insert this small electrode. So can we rely on that electrode that it will provide a good stimulation? So that's the reason why we choose right side ABI for this patient. What do you think? Shall we do it sequential or simultaneous?
I feel sequential.
Why?
I think this child may have other issues and there is a
normal.
leak. No, she's normal.
Yeah.
Suppose there is a leak or something, you want to just make sure one side is okay.
Yeah, but audiologically, do you expect, for example, so you can tell me, Dr. Levin, do this side and wait for 6 months until you do the other side. But what is the waiting period? I
think matching ABI.
I think we should conservatively. I cannot say from your perspective. From our perspective at our clinic, we would, if we are getting a response on the left side, we would be encouraged to do cochlear implant for the left side.
Yeah.
And if at all ABI is an option for the child, however, in our scenario, we would not give an ABI as an option because the funding and other factors plays a role. But say I remove the funding aspect and even ABI is there for the child, we would definitely evaluate the child with cochlear implant, how much progress is happening. If not for a longer period, at least for a short duration, say 6 months, or to look at the progress that the child is doing with cochlear implant. And if there is a scope, of course, there is undoubtedly for bilateral, the child will do better. But if the child is doing above average or moderately average, then it becomes a family decision to go further beyond that or not.
Yeah, that's an option.
I think your point here is that with that hypoplastic cochlea, limited number of electrodes, an extremely hypoplastic nerve, all those see an option on the left side, but what you're trying to say is that you're not really going to expect very much audition from that side, and that child is probably going to be relying more on the ABI on the right side, and this is only going to support the, so it's, if you look at the other way around, what you're saying is sort of bilateral ABI, let's do ABI and a cochlear implant. I think that's your
For
approach.
this case, definitely bilateral ABI is not indicated because there is a little response.
Exactly.
So, but that CI side is not good enough to provide the lifelong CI for that child. So we also think simultaneous operation, not to lose time in these cases, because we do simultaneous surgery. Yeah, we do simultaneous surgery for cochlear implantation. Why? What? ABI has now become, now it is about 3-hour surgery in our because we have done a lot, but with the good neurosurgeon. I'm not doing the surgery alone. So, so CI surgery sometimes is more complicated. To find this, look, to find this hypoplastic basal turn.
That's going to be it's much harder.
Very difficult than the ABI actually.
I would agree on that, yes.
Dr. Melikari,
yeah,
so actually, but to do, we have done 4 cases like this, simultaneous. Sometimes CI is more difficult than the ABI. So we first do the CI side and then do the ABI because after ABI it is impossible to do CI. That's one thing.
So we have, so we have this, so I've understood your philosophy. We do ABI, I mean we have been going more on the first try the CI and then the ABI. We have one patient where we've done both, but that was done sequentially. So we haven't progressed to that level where we would go in and do it simultaneously. But that might be something that we will.
Ultimately, we don't want to lose time actually for this case. Dr. Melikari, you know, this is the last lecture, maybe people are going home. Please let me know when to stop because 2 o'clock? Okay.
We want to leave at 2 o'clock. We need to have a bit of lunch also.
Oh.
Another 10 minutes?
Another 10 minutes, okay. Okay, so this was...
I'm sure you have enough interesting stuff to keep us occupied for the whole night.
Exactly. Sorry about that. But, I mean, I don't want to delay other people, but this was also a very hypoplastic aperture.
Yeah, again, you can see an aperture stenosis.
You see stenosis.
Is the cochlea hypoplastic as well, or is it a normal size? Looks okay.
From this image only, I think it looks okay, but
okay.
that's the reason why we included the aperture abnormalities into the classification. Because once you include that, you look specifically to that area as well, because it changes the prognosis of the patient considerably. So please look at the MRI and see if there is any nerve. You see, this is the left side. There is something
There's
here,
something going on the right side.
but it's not going
Not in the right direction.
Yeah. You see, most probably the facial nerve, but there is nothing going actually into the cochlea.
There maybe, is it? Is it? I don't know. Very hard to say.
So we tested again with our audiologist. After many tests, there is no response on either side. So
ABI.
So this is a unilateral ABI case for us.
Yeah, we would do an ABI. That's it.
Maybe if the family is interested in the contralateral, we can do that as well. But there was no response, no nerve.
Yeah, so we would counsel for an ABI.
Yeah. So we also developed an electrode with which has 3 contact points. Can you see it? I don't know, on the screen.
Yes.
So this is an electrode actually to test if we insert this electrode into the cochlea, there is a response or not. So our point was, we published this also last year, and we were making 2 centimeter incision. We were using this test electrode. If there is positive EADR, then we were making slightly larger incision, placing a cochlear implant. If there is no response, then we close that 2 centimeter incision, retrosigmoid, and we make an ABI. This was our original idea, but there are some conflicting results as well. I will ask your opinion about this patient. What do you think about this tomography?
Well, you of course see both the cochlear and vestibular segments.
Yeah, this is the cochlea.
So
It's a anti-cystic cochlea.
IP1.
IP1.
This is an IP1.
IP1.
Yes. So if you look here,
There's a nerve going in there.
yeah, if you look here, we can see actually
Now going there.
the nerve going into this
Clearer on this
anti-cochlea.
left side, yes.
Okay. So, and this is the sagittal oblique cuts.
Yeah.
If the size of the internal auditory meatus is good, we can see the nerves actually. We can tell the nerve is missing or hypoplastic. But unfortunately, we have narrow IECs where the nerve is there, or it is difficult to say whether the nerve is there or not. But in this patient, the nerve is there. But this is the intraoperative test electrode result, which our audiologists repeated, and they told me there is no response. So,
It's a difficult one.
it is,
You've got a cochlear cavity, you have a good going, visibly good nerve.
yes.
What was on the conditioned audiometry or the behavioral observation audiometry?
There was some response. I don't remember exactly, to tell you the truth. But intraoperatively, you have to make a decision as a surgeon, because
But the trouble is that I think that our experience, we don't have experience with the intracochlear testing, we have some experience with trans-tympanic LPR recordings, and the trouble is that of course it's not sensitive enough, it's reasonably specific. If you get a response, then you're encouraged, but the lack of a response doesn't necessarily mean there is no response.
exactly.
So at least in
If
the
there is positive
trans-tympanic
response, you can rely on this. But if there is negative
response, then you now, as I said, our experience is with trans-tympanic. I'm not sure whether it's the same with intracochlear.
Can your audiologist report their experience with this trans-tympanic
So basically,
electrode in hypoplastic nerve?
yeah, so if, as he said, that it is very specific and positioning is very important. So the right position, it is highly likely that you will get a positive response. And if it is positive, means it is true. So there is no false positive. There can be false negative response.
False negative, yes.
So there is no false positive response in TTVR.
Okay.
So it is highly specific. Sensitivity is low.
So, as the head surgeon in the operation, Dr. Medicari, this is the negative results, but you see the nerve. Dr. Amin, what will you do?
I will go ahead and put the implant.
I would still counsel.
Which implant? Of course, we are going to put
Cochlear.
the implant. CI or ABI?
I think in such cases the audiometric threshold matters so much and the aided response in this. So we have to put everything together.
Yeah.
We can't
You're
just,
right. You're right.
And if we are getting positive there, positive on radiology, so 2 ticks can overpower one wrong,
Yeah.
one cross.
So you know what I have done? I look at the MRI once again. I see the nerve. So if I see the nerve, I cannot place an ABI on a child. We did the cochlear implantation, and she has now perfect hearing and language development. So this is my message. I mean, we have this additional test, but please, every patient is different. That is my message. I mean, look at the scans again, but objective tests, if they are negative, may be misleading. This is another 2-year-old female patient. What do you think on the tomography? Everything is okay? The aperture, this is axial view, and this is coronal, is smaller than normal.
Narrow.
And this is the left side. Again, it is smaller than normal.
Yeah.
Okay. And this is the MRI.
Don't see a nerve.
We don't see any.
I don't see a nerve, I don't see CSF going to.
Yeah. Okay.
Okay.
But this is our audiologist. You know, she says there is a threshold there, and this is the aided threshold. You know, these audiologists, you know, complicate our.
Well, I always thought they make our life easy, but sometimes they make our life very difficult.
And actually, the audiologist here was very important. She's my wife. She says that she's very patient with the children. She loves children. Pediatric audiologist spends hours with them. She says there is a responsibility.
Well, then you have to listen to her. And in any case, you have to listen to her. She's your wife.
We have a committee.
You have no choice.
So there's no other choice.
Well, you don't have a choice anyway.
But on the right side, there was no response. So what are we going to do?
Offer a cochlear implant on the left side.
So we did the cochlear implantation on the left side, and so the left side was operated 2011. Okay, don't look at this image and ABI. We had first thresholds. You see the CI thresholds? Excellent thresholds with CI, but the child made progress at the beginning. She learned the simple things, simple commands, simple language, but then it stopped. Stop. No more progress.
That's because the nerve is so hypoplastic. So you're going to get auditory thresholds. You're going to get some addition, but it's not enough information for her to develop speech and language.
But it took us, when we see the progress of the language development, we waited. And then when it stopped, we discussed whether we should do ABI or CI on the other side. And by the time we made the ABI, it was 2 years after the CI surgery.
Can I just say something? If we go back.
Yeah. Go back to the audiogram?
Yes, if we go back to the audiogram. So if we have such nice aided thresholds with hearing aid, it may be too early to say, but we have observed that some of the hypoplastic ones, they do better with hearing aid than with cochlear implant because acoustic stimulation better than electrical stimulation. We don't know the reason why, but it would have been nice to look at the aided corticals with the hearing aid, and then look at the aided corticals with implant. With looking at such nice aided audiogram with hearing aid, maybe this child would have done better with hearing aid than cochlear implant.
It may be better to follow
the detection can get better with cochlear implant, definitely. But in terms of speech and language development, as you said, then there was a delay in that, and it was not getting. Sometimes with hypoplastic nerve, we have to optimize the mapping parameters so much that we really don't know how much we are, giving the charge, because the nerve is so hypoplastic, whether it cannot take that charge. So acoustic stimulation sometimes is better in cases of hypoplastic nerve where there is good aided audiometric threshold with hearing aid.
I completely understand you. But in an MRI like this, that actually we are seeing the other nerves. So the MRI shows us the nerves, but there is nothing going here. So to rely on hearing aid, it's not a good.
I know there's lots of gray area, and we have to learn so much. But we have a child who is wearing cochlear implant one side, hypoplastic nerve both the side, in transtympanic, positive transtympanic EABR both the sides. One side, the aided response was better, and it was a very tough decision for us. Of course, the surgeon wanted the better ear to implant, but we were very conservative and we didn't let go the better ear for that child, and we fitted him with a hearing aid on one side and cochlear implant on the other side. We have compared the results with hearing aid. His speech and language perception, the detection is better with cochlear implant, but his speech and language perception is better with hearing aid.
Our first case was like that, the one I presented. She had a single nerve undifferentiated in the right ear. She had better perception in the right ear. Why she was not implanted in the right ear is because in the MRI, in the left ear, they were showing two nerves. So maybe that was actually a good by chance, and she continues to wear the hearing aid in the right ear. And
maybe the nerve goes with the electrical stimulation.
These are difficult cases, but this is how we manage this case. It took us 2 years, and we also looked we presented these in 2015 in Toulouse, CI and ABI. So these are the patients, the first 6 patients that use CI on one side and ABI on the other side. These are the auditory perception with CI, with ABI, and this is CI and ABI together. So I think we may have some different views, but in complex cases like the CI and ABI is much better. And these are the thresholds before ABI, CAP scores before ABI. These are after. This is the speech intelligibility rating before ABI and after ABI. So there is a dramatic increase after ABI in these cases. But the problem is the sentence I write here. It took us 1.5 to 2 years to make this decision and actually make the operation. So I think we have to act a little bit early. That's the reason why in selected cases, I want to show you just one more case and then finish. We can also do the surgery simultaneously. That's the reason. But I have nothing to say to follow these children with CI. I mean, if I don't see the nerve, I think it is a little bit difficult decision, because after 2 years, if there is no good progress with an MRI report saying no nerve, or so there will be no improvement. And as a surgeon, the team, I'm the head of the team implant, so I'm responsible for everything. It will be a difficult situation.
So the aided corticals can give us some light in the whole thing with the hearing aid also, because the hearing aid threshold I saw was around 40, 50. So there was a chance we could have investigated in the left side that aided thresholds, corticals aided, if there's some activity happening at the cortex level, there's a good chance that the child could have progressed. That's all I can say.
For auditory neuropathy, we do a long latency response. But I think in this, the aided was of the left ear. Right ear aided was not there. They were blue. It was left ear. Right
Yeah, left ear. Only left ear.
Yeah.
So, just one final case. And this case was actually sent to us from another country. The child had bilateral hearing loss. They went to another country and they took MRI and tomography, and they diagnosed this patient in a very good clinic as bilateral cochlear aplasia, and they referred to us for ABI. Bilateral cochlear aplasia. So yesterday we have seen the classification, we have seen a lot of images. What do we see on the right side? This is the right side.
See a very, you're asking that?
Everybody, yeah. I mean, what is the right side?
Well, we see a very wide and internal canal. We
And?
see a big cavity.
Cavity.
And the question, of course, which you're asking them is this a cochlear aplasia with vestibular dilatation, or is it a common cavity?
Yeah, what is your opinion?
Common cavity.
Common cavity. Finished. So, if somebody says cochlear aplasia, you look at it. So this is a common cavity. On the other side, there is another common cavity, but then we have to check the nerve, huh? And this is the MRI. So this is the left side, this is the right side, and anybody want to make a comment? Of course, I cannot show you all the scans, but at least you can have an idea.
There's some sort of common, if you go to the right side, there is. I'm not
This
sure.
is the right side.
Yeah,
What-
so whether it's a common cochlear vestibular nerve.
This is a common cochlear vestibular nerve.
And it's branching.
Hmm?
Is there a branching there?
You know,
I don't know.
it is a very good sized common cochlear vestibular nerve. You're
Yes.
completely right. On the left side, can you make a comment? This is the best section showing the internal auditory canal.
So there is a nerve going in the anterior compartment. Now, whether is that the facial, it depends on the level. Is the facial? It can't be. I'll be very surprised if that's a cochlear nerve with that bad cochlear malformation. But,
Yeah, there is nothing
There's
on
it.
this side. So this is bilateral common cavity, and there is no internal or no nerve going into this smaller one. But there is a cochlear-vestibular nerve going to the other one. So
may I ask, on the, so that's clear, on the left side, would you term it common cavity, or would you say aplasia with
audiogram of this patient, she doesn't know when she